So for
Yes.
this, first I would like to welcome you all on this special evening, the first Brandos meeting of the new year 2025. And for those who are new to this forum, Brandos is the Breast and Endocrine Society of Western Uttar Pradesh, where all the medical professionals with a special interest in breast and endocrinology, they join on the last Friday of the month at 7 p.m. and where we discuss about breast and endocrine related problems, with breast related problems on every even month and endocrine related problems on every odd month. And we are proud to say that we are hosting this program for, we are about to complete 3 years, and there are more than 30 different topics from breast and endocrinology that we have taken so far, and we are pledged to take it to the next level in coming years. So being this obesity is a metabolic problem, endocrinology is no exempt. We cannot just separate, it is a metabolic problem, a part of endocrinology, and we just thought to discuss this problem, this very very important problem in this forum. Reason being, in the recent surveys, it has been found that in India, even in India, around 13 to 36% of Indian population is obese. तो जो ओबेसिटी है, वंस इट वाज थॉट कि इट इज ए प्रॉब्लम ऑफ एफ्लुएंट सोसाइटीज, जहाँ पे बहुत देर इज लॉट ऑफ कैलोरीज टू कंज्यूम, देर इज वेरी लेस हार्ड वर्क टू डू. बट इफ यू सी इन योर नेबरहुड, you could see that there are even not so rich people or even poor people who are obese. They are working hard, but still they are obese. So it is not only the matter. Of course, it is a lifestyle problem, but is there something else which we are missing? And what are those factors? What are the various ways through which we can modify our lifestyle? What are the dietary modifications, tip and tricks? With these points in mind, we have put in this program today. And I'm really excited because we are going to learn a lot from the experts that we have on our panel. So before I start the program, I would like to introduce one of my moderators. Our other moderators are a bit busy, so they may join us late. Our Dr. Anurag Srivastav sir, he is a very senior surgeon from a former head Department of General Surgery, AIMS, teacher of teachers, and right now he is heading as a director Subharti Cancer Institute. We are fortunate that he is serving Meerut right now. So he will join us late. Dr. Vishwajit Bembi sir, he is a very senior physician and with a keen interest in academics. So he will also join because he is stuck with some of his emergency patients. So he's a director of internal medicine, Department of Internal Medicine at Nutima Hospital, Meerut. And Dr. Chani Jain, she is a very senior pathologist, head of Shastinagar Diagnostic Center, Meerut. All those uh, who have been to Brandos, they know her very well. And apart from that, we have our speakers, a panel of speakers, very, very senior people that we have right now. So we have Dr. S.P. Sondi sir. Thank you, sir, for joining us tonight. And he is a very senior physician with a special interest in bariatric, in obesity management. So I could say that he is one of the bariatric physicians that we have. And yeah, and he is the director and head of uh, 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 he's a very very senior physician of Meerut, and I'm fortunate that he is with us tonight. And we have Dr. Magan Mehrotra sir. Dr. Magan Mehrotra is a senior bariatric surgeon, and he is among those who have set up a dedicated bariatric surgery department in Western Uttar Pradesh. He is right now head of Department of Bariatric and Robotic Surgery at Apex Hospital, Muradabad. And I'm fortunate that we have a very good connect at Nutima also. So we as a team work on the obesity patients at our center. We have our third speaker, Dr. Samyak Jain. Dr. Samyak Jain is a very senior psychologist and with a very, very keen interest in patients' suffering with obesity. So today he is there with us sharing his insights on how to tackle the psychological aspect of overeating or other issues that these patients deal. And we have our fourth speaker, Dr. Nirupma Singh. Dr. Nirupma Singh is a senior dietitian from SGPJMS Lucknow. So she has a huge exposure of patients with dietary disorders, and she knows how to deal with the diet, how to do the dietary management of such patients. And today she is going to give us the tips and tricks and various insights on dietary management in obese patients. So, uh, Dr. Chani is with us. Dr. Chani, would you like to make some announcements?
Yes, thank you, ma'am. We will request all our participants to please keep their mic on mute during the presentation, and any queries can be posted in the chat box. Our eminent speakers will take them up at the end of the session. Thank you for cooperating.
So, without wasting much time, because we have a very uh, long presentations that are in front of a huge amount of information that we are going to consume, so it will take some time. So I hand over the podium to all our speakers. So I request Sondhi sir to he will be our first presenter, and he will be telling about the pathophysiology as well as how should we manage the what is the medical management of obesity in patients. So sir, over to you, please. Thank you.
Thank you, Dr. Sudhi. Am I audible?
Yes, sir. You are very
Yes,
well audible.
perfect. And you will change the slide for me?
Yes,
Dr.
sir. I'll do that for you.
Thank you. Thank you very much. And for the first time, I heard this term bariatric physician. But you can jolly well call me this, because it was about 20 years back that I stumbled into bariatric surgery because one of my friends and classmate was very, very obese. And 20 years back, I got him operated for bariatric surgery. And I have personally watched about 20 bariatric surgery on my own. And so you can call me that. Thank you. It's been an honor to be talking about obesity on this very reputed platform. So all of us know a few things, and I'll try to kind of rush through in my time. Well, all of us know that most of the time we diagnose obesity with BMI, which is not too correct. Traditionally, we call 25 to 30 years overweight and more than 30 years obese. But for Indians, because Indians have more fat on a BMI to BMI basis, we bring it down a little lower, and we will call Indians obese if they are more than 27 or so. So next slide. All of us are aware that obesity is increasing, and in the next 10, 20 years, all of us will be dealing with it. Next slide. Well, like any other disease, obesity causes are in genes, behavior, and environment. So next slide. So we know that obesity is a polygenic disease. That means many genes are involved, not just one. And the heritability is about 40 to 70%. We have, all of us in our clinical practice have seen families who have obese individual. And so this is definitely genetic in origin. Sometimes even one problematic genes can actually result in obesity. And one of the most commonest one is melanocortin 4 receptor gene. But we are not going to talk about that. Next slide. And when we come to environment and our behavior, it is like we explain it to a simple patient that, there is an energy intake and there is energy expenditure. And so whenever energy intake, next slide, is more than the energy intake, we accumulate fat. And actually, basically, energy intake is a lot dependent on our mind. And in our mind, there is in the arcuate nucleus in the hypothalamus, which decides how much food quantity we eat and what are our preferences, and so on and so forth. So it also decides to a little extent our energy expenditure. Next slide. So if there is a gap, and this is just a pictorial way to tell you that if we eat just one paratha extra a day, then we are spending the energy. Then in about, as the year pass by, we will start accumulating fat. And in about, say, 20, 30 year, we'll be 40 kg extra fat if we are taking that extra. So it's basically a simple bank balance. And when we accumulate more fat, next slide, there is one more thing which actually adds to this. Next slide is doctors. Many times we make the patients obese, and it's not just anecdotal or anything. I see it every day. I see, like, a patient, a lady patient came to me. She had migraine, and someone gave her flunarizine, and after 3 or 4 months she was much better as far as migraine was concerned, but she had already gained 6 kgs of weight. So these are the medicine, and we have to be very, very careful when we prescribe these medicine in obese individuals. They can stimulate appetite like steroid, etc. They can decrease body metabolism like lithium. They can make exercise a little more difficult like beta blockers, cause water retention. And we have seen so many drugs here. And of course, decreasing lipolysis like insulin, etc., etc. So we are also many times the cause of making the patient obese. Next slide. Where we accumulate the fat is important. If the fat is in our viscera, it's much worse than in subcutaneous planes, because the visceral fat is metabolically active, releases a lot of free fatty acid, which goes straight to the liver. Liver is able to deal with some bit of it, but not all. And so there starts the fatty liver as well as the insulin resistance, and the seeds are sown for type 2 diabetes and other diseases. Well, we also are aware that there is a white fat and beige fat and a brown fat. When we are infants, we have a lot of brown fats. We call it brown because it has a lot of mitochondria, which are generating energy and heat. And so it spends the energy much more than the white fat. But as we grow older, we accumulate a lot of white fat. A lot of scientific research is going into whether we can convert this white fat into brown or not. Next slide. So how to diagnose? Well, all of us know that BMI is very, very useful, because you can just calculate by putting in the weight and the height, and you calculate the BMI, but it's not a direct measure of fat. It does not establish the distribution of fat, where is the fat, and it cannot determine when the excess fat is becoming a health problem. Like, to give you an example, if there is a obese individual who has acanthosis nigricans on his neck, he is already got insulin resistance. Then another one who has not yet got that. Next slide. So what inputs do we need? And even if we don't do it daily in our clinical practice, we should keep it in mind. We should, of course, know the BMI, which can be calculated very easily, but we should also know fat mass. Does the patient have more of fat mass or muscle mass? And, there are some chemistry type of machines which by bioimpedance check your fat quantity in your body. The other ways are more stringent and more difficult to do, like MRI, etc. And simple waist circumference tells you a lot about whether it is fat or muscle mass. And in the end, what clinical problem the patient is facing. Is he or she is having type 2 diabetes? Is she having osteoarthritis of the knee, or what? Next slide. And these are some, examples of patient. Like, first patient has a BMI of 23.7, and he's normal. There is no obesity. There was no excess body fat, etc. The second one has 28.8, and he also doesn't have any extra body fat, etc., and he's overweight. Then you go into 28.8, again, the similar BMI, but if you check his body fat, it's extra. So he actually is preclinical obesity. He's almost become obese even when his BMI is 28. And it only means that when you look at the patients, the BMI could be high even because of the sum of the muscle mass. So we got to keep that in mind. And if the patient already has some signs and symptoms related to obesity, that is the worst kind of patient. That means the patient has already started suffering. Next. Why to treat? Well, long years back, Hippocrates said that sudden death is more common in those who are naturally fat than lean. So we know it should be treated. Next, as the BMI goes up, next slide, the mortality keeps going up. The obesity is a common link for all chronic disorders. Some are mechanical, like osteoarthritis, knee, etc. Other are metabolic, like fatty liver. Another mechanical one is sleep apnea, and then metabolic like type 2 diabetes, dyslipidemia, coronary arteries, heart failure with preserved ejection fraction, and so on and so forth. For the paucity of time, we won't go into the details of each one of them. Next slide. Well, we should not forget that obesity increases the risk of many cancers, and here is a list if you want to go through that. But please remember that excess cancer risk is seen in obese individual. Next slide. Once we have diagnosed and is understood, then we have to treat. And this is a I love this quote, is by Yogi Berra. Yogi Berra was a baseball player who turned into a corporate management guy. He said, if you don't know where you are going, you may not reach there. Very interesting quote. That means when you are starting the treatment, you must know how much you require the patients to bring down his weight, and we should set the aims. Next slide. Well, this slide shows that what advantages the patient gets if he loses 5% or more. You can see here, when he loses about 10%, there is type 2 diabetes prevention, physical function improves, glycemia improves, and at around 10-12%, the CV risk reduction starts coming down, hypertension is brought down, sleep apnea, even with about 7 to 10% reduction, it gets better. If you want a type 2 diabetes remission, then you have to lose more weight, around 15 kgs or so. Next slide. How do we achieve that? We achieve that with psychological intervention, about which the next speaker is going to talk, and some dietary therapies and physical activities. And then we reach the pharmacological therapy. And then ultimately, if all of us fail, we go back to bariatric surgery. The only thing I'll mention here that sometimes even this fails. And if this fails and the patient regains the weight, we come back to pharmacological therapy again. So it's kind of a circle. Next slide. So diets are usually not the answer, because when you're doing very strict diets, you lose weight. Next slide. But when you follow up, all this lost weight is gained back in most of the studies. Next. Why do we regain weight? Is that when we become thinner, there are some things which are triggered in our body. Like if we have lost weight because of diet or exercise, then the hunger is stimulated. There is low satiety. The hunger hormones go up. The energy expenditure comes down. That means there is adaptation, and body wants to gain weight. And that's why I have the next slide, which says that people who are no longer obese are different from those who were never obese. Let me make it simpler for you. There are two individuals of 70 kgs of weight, which is their ideal weight. One has lost it from 90, and other has never, ever been obese. Now, the one who has lost it from 90s is more likely to regain it back, because there are adaptive mechanisms working in him, and they continue to work throughout life. And that makes the task very, very difficult for for these people who lose weight. Next slide. What about exercise? Well, you'll have to do a lot of exercise if you want to lose weight. For just burning 1 pound of fat, you'll have to burn around 3,500 calories, run around 25 miles, cycle around 65 miles, and so on and so forth. It's not easy. Even if you do that, you may not end up losing weight because appetite may be stimulated and other things may happen. Next slide. So we have to fall back upon drugs, and it's a very exciting time for us to be here because initially we had very few drugs like orlistat, naltrexone, bupivacaine, but now we have GLP-1 analogs, and we want to talk about them. And gradually we are learning more and more about them. These are the drugs which are akin to GLP-1 hormone, which is secreted from the gut when we have our meals, and this gives us satiety, and this reduces the weight. Next slide. So what is the protocol? Well, if you calculate and the patient is mildly obese, well, you undergo medical nutrition therapy, physical activity, lifestyle changes, and then come to medicine. But if you are moderately obese or you have additional medical problem with you, then we start with pharmacotherapy immediately. And if the patient is pre-diabetic or diabetic, we will prefer GLP-1 because they treat diabetes also. Otherwise, we can start with other drugs. Next slide. And next few slides, I will devote on GLP-1 analogs, which we are using. Unfortunately, in India, we don't have yet the injectable GLP-1 analogs, which are much more effective as weight-reducing drugs than oral. We just have a semaglutide oral tablet, which is not as effective as injectable. And even when we use injectables, we use a little higher dose, like semaglutide for controlling diabetes is used as 1 milligram subcutaneous weekly, while for obesity we use 2.4 milligram subcutaneous weekly. The patient, these studies which I'm showing are actually on obese drug dosage, and here the average weight loss was about 14 to 15%. Next slide. And when you lose about 10 to 15%, the diabetes is prevented, glycemia is controlled if the patient is already a diabetic, hypertension comes down, sleep apnea is of course cured, and other things. Next slide. And then we have a tirzepatide, the dual agonist. We had forgotten about the GIP long back because there was few studies which showed that GIP doesn't work in diabetics because of GIP resistance. So GIP was actually kind of put in a trash, but then it is reinvented, and this drug has GLP-1 as well as GIP both analogs, and this worked better than the GLP-1 were alone. So the weight loss was about 23% in 21% in such individuals, huge. And next, now we have a triple drug combination. That means, can I have the next slide? Yes, this is a triple drug combination which has a GIP, GLP-1, and glucagon receptor agonist. And some of you may say, why should a glucagon receptor agonist be added? Because glucagon increases the blood glucose, but it also decreases the energy expenditure, and it also gives you satiety. So here they have these drugs, they have used all these combination in a novel drug, retatrutide, where the weight loss came down by as much as 25%. So we are actually approaching the bariatric range now, and I'm very excited about this. Next slide. Well, when you treat obesity, you treat obstructive sleep apnea. So this is a tirzepatide for obstructive sleep apnea. This is the only drug approved for treating medical treatment of sleep apnea. Next slide. And same is true of osteoarthritis. And yeah, Sudhi came to the another slide, but yeah. So this was a recent article in Economist, which talked about how GLP-1 analogs are going to change the whole scenario. And they are being almost talked about in a fashion that this is a major drug discovery, and you are going to hear about them in the next 10 years more and more. They are like Swiss knife doing so many things. There are anecdotal evidence that they bring down inflammation, and so many patients, their rheumatoid arthritis or other diseases get treated. There are initial evidences available that they decreases the addiction potential in the patient. So many of the time, many patients have actually kind of leave alcohol and other addictions. And there is also some evidence that Alzheimer's could be improved with the use of this. In any case, Alzheimer is called as type 3 diabetes, which means there is a resistance in the brain to insulin. And there is also some evidence that they can increase the age also. There is a lot of potential in them, but what will happen, we'll see. Soon, they are going to become cheaper because semaglutide injectable probably is going to go off patent in 2026 late in India. So we will have a cheaper option. Next slide. The only thing is that the only problem they create is extreme loss of appetite, nausea, sometimes diarrhea, sometimes vomiting. And so when we use these drugs, we have to remember that we have to advise patients to eat slowly and have small meals, stop before feeling full, avoid fatty and spicy foods, excess alcohol, otherwise they will have nausea or vomiting. Avoid lying down or intense exercise after meals so that their side effects are less. Next. So this is the summary, and I hope I have finished it in time, is that this is a clinical disease with complex etiology and significant impact on the patient's health. The diagnosis should be appropriate. Obesity treatment should be carried out in a professional setting, and the target should be at least 5% weight loss, maybe more. Weight management should be supervised by a qualified patient, and no single method can provide optimal result. Newer agents are very, very exciting. Thank you. And this is my last slide, and I invite you to hear my Chai Pickup Shop podcast on Spotify and other places. Thank you very much, Sudhi. Over to the new speaker. Unmute, Sudhi. Unmute.
I'm sorry. Yeah, so multifaceted personality, sir. I must congratulate you for you simplified such a complex topic in a very, very simplified form, and in the time that is being provided to you. Thank you very much, sir. And since our other speakers are waiting, so I request all the participants they keep on writing their questions. Our experts will be there to answer all those. And as the medical part we have covered, so important part is bariatric surgery is in the trend, because I could see even the families, each and every member of once any किसी एक का अगर सर्जरी होता है, I could see पूरी फैमिली धीरे धीरे वो सर्जरी कराती है. And bariatric surgery is really in a trend. But what is the exact reality? बेरियाटिक सर्जरी की रियलिटी क्या है, इसके लिए मैं इनवाइट करूंगी डॉक्टर मगन मल्होत्रा सर. आई हैव ऑलरेडी इंट्रोड्यूस हिम टू यू, सो आई रिक्वेस्ट सर टू प्लीज टेक ऑन.
Thank you, Dr. Sudhi, for giving me this opportunity to be amongst the elite audience here. And it was a very comprehensive talk by Dr. Sondi sir regarding the medical management of obesity and regarding the pathophysiology. So before not wasting time on not repeating what sir has said already, I will directly go to weight loss surgery. And I have tried to make my presentation more effective by talking about surgery only. although we all understand that now in the present time, we have to consider medical treatment along with surgical treatment because of the load of the disease as such. Obesity is very common, and also because it has different grades, and so one size fits all is not a good policy. So my goals through this presentation are describe obesity and health effects of obesity, describe weight loss surgeries, pre-operative and post-operative work, and also to talk about the obesity management medications that Sir has talked about in the context of bariatric surgery. Next slide, please. So where should we get a bariatric surgery done? It should be done in a tertiary care hospital with ICU and cardiology backup, and hospital services should be catering to multiple different things. First thing is that a specialist who is genuinely interested in treating the obesity should be there, and those will be surgeons as well as physicians. Next slide, please. So body mass index Sir has already talked about. Next slide, please. So different perceptions of society, obesity has been seen as a weakness or failure of individuals. Uh, so I will like to disagree with my previous speaker regarding the calorie in and calorie out equation that has been in place for hundreds of years, that you eat more because you eat more, you are obese. So definitely the obesity is triggered by some point in time when there has been more calorie intake and less calorie output in an individual's life when it started. But then the hormonal milieu in the body changes in such a way that even if this person has corrected his calorie intake and calorie output and also his lifestyle and habits, he or she is not able to lose that weight because he or she has reached that point on the BMI scale, to say very grossly, on the BMI scale, that his or her body is now guarding that weight. Like our hemoglobin does not fall when we donate 1 unit of blood. Our body makes that up in 15 days. If I take a hot water shower, I will not have fever. If I take one rasgulla right now, I will not have diabetes because my body has homeostasis. It is trying to maintain my blood sugar, my temperature, my hemoglobin, and similarly, it is guarding my weight. And that is why it becomes very difficult to lose weight once you reach the morbidly obese category. And that is why the differentiation between morbid obesity and obesity. So that is where surgery or the GLP-1 receptor agonists have come into play now. And next slide, please. So now in the present, obesity is considered a disease and a cause of many serious health conditions, and surgery has gained acceptance as the only proven method to treat this disease beyond a certain level. Next slide, please. So I will not go in so much detail, but we all know that the medical and health implications of obesity are great. And as you can see, 400% increase in diabetes is seen when BMI is greater than 30. And we all know that India is going to be the diabetes capital of the world. In fact, it is already the diabetes capital of the world with the maximum number of diabetics in a single country. So these are again comorbidities. This is how we classify obesity. And I will concentrate on the BMI greater than 35 group only, because before that, we have very good medications available now. And next slide, please. So who are the potential candidates? So grossly speaking, if somebody is 30 kgs above ideal body weight or has a body mass index of greater than 40 or 35 with significant comorbidities, and age is, if somebody has attained the age of 18 years, then that person qualifies. I think 70 plus is also in our mind. The patient should be fit for surgery. Failed attempt at weight loss should be there. So all the patients should earn their surgery. They should first have corrected their lifestyle, because after surgery also we want them to correct their lifestyle so that they keep the lost weight in place. Next slide, please. So remember, all surgeries have risks. Not all patients are candidates for surgery, and we have to discuss these options with the patients at their very first visit. whether they can be handled only with surgery, or they can have a uh, better prognosis with medical treatment. Next slide, please. So mainly we have two options as far as the surgical options are concerned. One is a gastric bypass and second is a sleeve gastrectomy. There are actually 35, 36 different procedures that have been described by different specialists. But I am talking about only those two procedures where we have the maximum experience, and they more or less cover the whole spectrum. So there are two kinds of operations: restrictive plus malabsorptive, and the other is restrictive only. So restrictive plus malabsorptive is a Roux-en-Y gastric bypass, where we make a small pouch which is connected to the mid to distal jejunum, and the food directly goes from the gastric pouch into the jejunum. Therefore, this naturally stimulates incretins like GLP-1 and GIP, PYY, and other such hormones, which act like insulin, and so they increase the BMR of the patient and also increase the glucose utilization. And thus, besides doing restrictive, they are also helping the hormonal milieu to reduce the weight of the patient. While in sleep, which is mainly restrictive, the patient loses weight mainly by restriction, but definitely there is some increase in GLP with sleep as well. Next slide. So this is what I just said, and disadvantages of gastric bypass are mainly because we have changed the way the food goes. There are nutritional deficiencies, and there is dumping syndrome when patient consumes high amount of calories. Next slide, please. So early post-operative gastric potential complications, death is very uncommon. Pneumonia is also uncommon with the laparoscopic approach because the patients are able to breathe well after laparoscopy because there is no big incision. And infections, again, with laparoscopy, they are very less. And leaks are there. 1 in 600 is the risk of leak. And rest others are very uncommon or minor complications. Next slide, please. So late complications, again, the main complications related with the gastric bypass are nutritional problems. And these nutritional problems can very well be taken care of if the patient takes care of their vitamin intake and their protein intake. Next slide, please. So it significantly restricts the amount of food to summarize, there is restriction. Then dumping syndrome can occur if there is high calorie intake, and we should expect 70% of excess body weight loss. So if a patient has to be, for his ideal body weight, it is 80 kgs, and if the patient is 140 kgs, so out of the 60 kgs that the patient has excess, he will lose almost 42 kgs with a gastric bypass after 2 years of the surgery. So sometimes the patients are fearful that they will lose all their weight. So this is not true. So we need to counsel them that generally the weight will stop. They will stop losing weight much before their ideal body weight also. So then they can work hard and get themselves to the ideal body weight. And patients have to consume high protein meals every day, and vitamin and protein deficiencies are usually preventable with adequate protein intake. Next slide, please. So what is dumping syndrome? Stomach contents move rapidly through the small intestine following surgery. And when they are high osmolar load, then there are two things happen. One is the increased insulin secretion, and secondly, they bring water into the intestine. So there is sudden dizziness and hypoglycemia, which causes headache, sweating, nausea, and sometimes diarrhea as well. So we have to instruct the patient to not to take any high calorie fluid or high calorie solid also, and especially not to take fluid with the food, because that helps the food to go directly into the small bowel very fast. Next slide, please. The sleeve gastrectomy, approximately 2/3 to 3/4 of the stomach is removed. It is a single stage procedure and has much less complications. Advantages are there is no dumping syndrome, malabsorption is not there, so vitamin and protein requirement after surgery is minimal, and the main way it works by is feeling of fullness. Next slide, please. So it is a surgery on only the stomach, no rerouting. The preferred surgery for any transplant or dialysis patient or any patient who's on multiple drugs, we avoid a bypass because bypass reduce the absorption of these drugs. So sleeve is a better option. and we could expect 50 to 60% of excess weight loss at 2 years with sleeve as well. The main problem with sleeve actually is the weight regain. So the patient should be very well motivated, and this patient should also uh, uh, understand that the lifestyle changes that he or she is are making have to be permanent, and they should be in good physical condition to make those lifestyle changes. So my preference would be to go for a Roux-en-Y gastric bypass if it is a 55-year-old female who has already developed osteoarthritis, although she may not have metabolic syndrome, but I will do a more stronger procedure for her, because I know that I cannot expect her to be walking 45 minutes at a go after surgery also. So with a sleeve, she would have more chances of regaining weight. Next slide, please. So how to maintain success? Surgery is just a tool to assist with weight loss. Patients must be committed to making the emotional and physical changes necessary after weight loss. The commitment will ensure successful weight loss. Lack of exercise, poorly balanced meals, constant grazing, eating processed carbohydrates and carbonated beverages are some causes of weight regain. And good habits of food intake and exercise will need to be practiced for the rest of patients' life. Next slide, please. So psychological evaluation is invaluable. If it is not done properly, then we are bound to fail. Nutritional evaluation, pre-surgery and post-surgery, both are important. Then these are the routine tests. Upper GI examination is just one extra thing that we need to do before doing bariatric surgery, because we are excluding a part of stomach, so we should have had a look at it before. Next slide, please. Again, other possible pre-op evaluations, we all understand that according to comorbidities, they will be required. Next slide, please. So insurance coverage has been approved since 2020 after intervention of the Supreme Court. BMI criteria have to be met. Body composition analysis report, if it is present, then the insurance is easier to, the company is easier to convince that this patient needs a bariatric surgery. Policy exclusions should be seen before promising the patient that it will be done. And coverage is important if they have higher amount coverage. Generally, I have seen if somebody has a 10 lakhs plus policy coverage, then it is less likely to be refused. And history and physical examination findings should be properly written. They should all be true. Otherwise, the insurance agents can check and then will lead to rejection again. Next slide, please. So hospital stay for laparoscopic surgeries are 2 to 3 days, and the patient has to be out of work for almost 2 weeks, because there are pretty much dietary restrictions also, and there is some pain. So they can work from home from the third, fourth day also. No driving for again 1 to 2 weeks, and no heavy weight lifting for a month after surgery. Next time. So gastric obesity procedures, diet that we usually recommend is a clear liquid diet for the first 2 to 3 days. Then we start opaque fluids, and we keep the patient on fluids for the first 14 days. So we can give them between meals. They can have 2 ounces of non-sweetened, non-carbonated beverages also, and they should keep sipping water and salt. Salt is very important, because when the intake becomes very less, the patient goes low on sodium and potassium, and therefore they start feeling weak. And what they do is they start taking glucon D instead of taking salt. So one has to counsel them that they have to take good amount of salt with water, so that they don't feel this weakness after surgery. It is generally not because of the decreased glucose intake, because if you see, they will be euglycemic, but the problem is of sodium and potassium. So they have to be encouraged to take every salt with every liquid that they are consuming. Next slide, please. So we have drastically limited the volume. Next slide, please. So we advise them not to drink water with meals after that. Once after 2 weeks are over, we give them semi-solid diet. So we ask them to chew their food well, take small bites, take a lot of time to eat it. And we also ask them to take small portions. We ask them to take small plates, small katori, small spoon, small glass, so that when they see the spoon, they are reminded that they cannot eat fast. So most of the times what happens is they start eating fast, and then they come back to us with nausea and vomiting. So we have to remind these patients that they have to go slow. Next slide. So we have talked about already. Next slide, please. So plastic surgery, this is one more thing that is on the patient's minds always. that once I lose weight, my skin will start hanging or my look will be bad in this area or that area. So they have to be told that they have to wait at least 12 to 18 months till the weight is stable, and we have to see whether their nutritional status is adequate, and then only we have to ask them to go to the plastic surgeon or to offer them plastic surgery in any way. And insurance rarely covers these procedures because they are generally cosmetic. Next slide, please. So tips to remember: all medications that are to be given to the vitamins and medications need to be chewable or crushed or liquid form for the first 2 weeks. And primary care doctor and pharmacist to help and adjust these medications. Some drugs are not safe to crush, so we have to make replacements. Next slide. So this is the more or less gross estimate of what we need to give these patients regularly. So 1000 mg of calcium citrate, vitamin D 800 international units per day, vitamin B12 250 micrograms daily, and ferrous sulfate elixir 325 mg daily for menstruating women especially. Pregnancy following surgery is to be avoided for at least 12 to 18 months. It is best to maintain a stable weight loss and plateau prior to becoming pregnant. And the patient should inform the bariatric surgeon also if she's planning a pregnancy, because we need to see iron levels and B12 levels and folate levels also, so that there are no congenital abnormalities in the baby. So follow-up is lifelong. Commitment has to be there every 2 weeks for the first 2 months, then three monthly for the first year, and then yearly for lifetime means 3 to 5 years. After that, the patient and the physician, the bariatric surgeon or physician also come to know what the patient is liable to, what deficiencies the patient liable to have, and such consultations can be done online also. The patient does not need to visit. Lab works can be checked in every visit. Next slide, please. So exercise is an important part of weight loss journey. Exercise has to be done daily, 30 to 45 minutes. And I generally advise the patients not to go for jogging or for bike riding or for weight training in the initial period, because morbidly obese patients have a bad body balance, and they can have problems with joints and mainly ankle and the lower back. So I asked them to just go for walks. It is yellow in this slide. I wanted to highlight it, but it has actually got diminished. So my highlight is that walking is the only thing that we need to stress on. Next slide, please. So encourage them to join a support group. We all bariatric surgeons do support group meetings. Here, what happens is they see their peers who have lost more weight than them or who are trying hard, and so they get motivated by seeing each other. And ideally, the patient should attend a support group offered by his own surgeon. But if that is not possible, they can go to support groups of other surgeons also, so that they keep themselves motivated. So now coming to the GLP-1 drugs and their impact on bariatric surgery. Next slide, please. So I am here quoting multiple studies which have been done in the previous years. And the first one was looking at metabolic bariatric surgery in the era of GLP-1 receptor agonists. And it was observed that a 15% decline in bariatric surgery procedures was seen over 2 years. But this decline was also included the phase when there was COVID in the year 2021 and 2020 to 2022. So this study had a flaw in that. Bariatric surgery versus GLP-1 drugs, mortality and cardiovascular study suggests that surgery is crucial for high-risk patients with severe obesity and diabetes. So surgery works well when there is severe obesity, when the BMI is higher. And so for the lower BMI patients who used to fall in the surgery category, we can still use these GLP-1 drugs. Next slide, please. Now, GLP-1 drugs in weight loss and bariatric surgery, this is a review that was done in obesity surgery, and it highlighted the synergy in post-operative patients struggling with weight regain. So such patients who, as my previous learned speaker had said, those patients who have who are starting to regain weight in the post-operative phase can be given these drugs, because actually surgery is also making this change only in our body, that is increasing GLP-1 secretion and therefore and also the receptor agonism is also there. So it is what the drugs are now mimicking is what the surgery has been doing. So if surgery, and what happens after 6 months to a year, these effects start getting reversed. So by giving this GLP-1 receptor agonist, we can augment the waning effect of surgery and stop the weight regain. Next slide, please. So GLP-1 receptor agonists in post-bariatric surgery patients this study reinforces the importance of pharmacological support alongside surgery, mainly for the again the weight regain patients. Next slide, please. So, in high-risk bariatric patients, GLP-1 agonists can be used to bring them to some lower weight as a bridge therapy before surgery. But then these GLP-1 agonists need to be stopped at least a month before surgery. If not a month, it has to be 2 weeks, because they can have multiple effects that are not desirable during the post-operative period. Next slide, please. So, utilization pattern of GLP-1 drugs prior to surgery. So again, this study advocated for multidisciplinary collaboration in treatment planning, but because there are very few studies done till now in such a way, and there is very less data. So guidelines cannot be formed on how to go about it, but they will very soon be there. Next slide, please. Systematic review of GLP-1 drugs in surgery. It discussed the potential for reducing long-term complications post-surgery, and it reinforced the importance of individualized care strategies. So again, guidelines have to come, and they're on their way, I am sure. Next slide, please. So endoscopic surgical treatment, endoscopic bariatric therapy has been in vogue over the last few years, but again, it failed to go beyond a point. So it is also being explored to combine GLP drugs with endoscopic therapies, so the patient can have a completely, let us say, no scar approach towards losing weight. But this is again in its infancy, and let us see how these things come up. Next slide, please. So comparative weight loss, GLP-1 drugs versus surgery. Pharmacotherapy is effective in moderate obesity with fewer complications, but for severe obesity, surgery remains the treatment of choice. Next slide, please. Obesity surgery in the era of Ozempic. Ozempic is one of the injectable GLP-1 receptor agonists, and it is the study advocated for combining pharmacotherapy with surgery for optimal outcomes. Again, guidelines are needed. So, in conclusion, GLP-1 drugs are transforming obesity treatment, but do not replace bariatric surgery. Surgery remains the gold standard for severe obesity and metabolic complications. GLP-1 drugs are effective in preoperative and postoperative settings for selected patients. Integrated care models combining pharmacotherapy and surgery yield the best outcomes. Future research should focus on long-term comparative efficacy and patient selection. Thank you. So, just to summarize what I have talked about throughout this presentation, and to summarize regarding GLP-1 receptor agonists, the drug therapy has been beneficial for everyone. It is not that as a surgeon I am trying to speak against GLP-1 receptor agonists. They are working very well for mild to moderate obesity patients, where we also wanted not to offer surgery initially. And the best thing is that now the physicians are also interested in obesity. They also want to convince the patient that obesity is a disease, because they also have something in their armamentarium to help these patients. So actually, the number of patients coming to us for obesity treatment is going to increase, and that is what we have been wanting all through. We wanted always to convince these patients that they recognize their obesity as a problem, as a disease. Now, how we treat that is completely different. It is a matter of research till now, but to convince them that their obesity is a disease was the biggest aim, and that will be fulfilled when we will work alongside the physicians and not in any collision. Thank you so much for a patient hearing.
Thank you very much, sir. And I must congratulate you as well, because in a very, very simple term, you shared very good insights on bariatric surgery. So, as a surgeon, I always tell my patients that surgery is always a last resort. First, we should manage any problem, if possible, with the medical or the conservative management, because surgery has its own risk. But definitely, whenever bariatric surgery is being done, patient sees the results within 2 to 3 months. The results are appreciable, and those are really very promising results, and the patients are always very happy. But definitely they have some side effects or complications. So we have a lot of questions for you, sir, Magan sir, but now our psychiatrist is waiting, and we all know in both the presentations we emphasize the role of psychological therapy or psychotherapy, and this is very very important, because once our goals are achieved, even after that we tend to regain weight. So what, and we can see in, even in children, even in adolescents, now the obesity rate is increasing in a very very dangerous level. And what are the various factors we would like to understand with Dr. Samyak, and what are the various remedies through which we can overcome these problem at our level. So over to you, Dr. Samyak.
Thank you, ma'am. Thanks for having me on board at this prestigious forum. And especially my guru, my mentor, Dr. Sondhi sir is here. So I am very honored to be present today here in this forum. Let's come back to the topic. As we know that, as we have already discussed, that it's a multifactorial disease, genetically determined, environmentally determined, and psychology has a very important role to play in the genesis of obesity. So let's come on to the psychological factors. So psychology is bidirectionally related to obesity, in the sense that it's a vicious cycle. Obesity, on one hand, has a lot of psychological impact on a person's psychological well-being, and at the same time, uh, the psychological makeup of a person in various aspects, like its personality and other traits, and its eating habits and all those things, has a strong role in causation as well as maintenance of obesity. So let's see what are the important psychological factors associated with obesity. Next slide, ma'am. So a person's personality traits, then every person has a different meaning, psychological meaning of food, right? That we'll discuss in detail in subsequent slides. And eating patterns of a person, and psychological status and psychological well-being, or whether there is underlying psychological morbidity, which can lead to obesity, and which can enhance the risk factors associated with obesity. So coming to the personality traits, uh, some people have high preference for high fat, calorie foods, uh, and many times people use food as a source of emotional comfort, and they use food as a coping mechanism to the stress. Such personality traits, and they are generally affected by culture also. In different culture, the food has different meaning, and in different culture, the personality of the races. We have seen that in certain races, the obesity is too much. At other races, obesity is, like in Japanese. Obesity is very less common among Japanese people, and in certain other races. So the cultural factors also determine the personality traits of a particular race in different cultures, which lead to risk factors of obesity. Next slide, ma'am. Uh, Likewise, psychological meaning of food. Uh, so the people who struggle with their weight, they have a different people have different meaning of food for themselves. For example, like during emotional conflict, many people resort to binge eating, high carbohydrate diet, high sugar diet. So all they have it becomes like they are comforting factors. which subsequently lead to obesity. So, if a person is using food as a friend in times of distress, rather than adopting other healthy coping measures, then this is one of the in today's stressful lifestyle era. This is one of the very common factors leading to obesity. Like I said, that when at times food becomes the best friend, especially in certain populations, like people who spend long hours alone. So what they do is like they resort to eating and a lot of screen time. So and screen when a person is resorting to a lot of screen time in front of social media or television, it leads to senseless and mindless snacking at an unconscious level. So, if you are watching something for long hours and spending a lot of time on screen, uh, then person tends to eat along with it. So, so if a person is spending too much time lonely or with gadgets or in front of screens, and naturally his calorie consumption will increase. Uh, so people start using food as a close relationship also. Such situations are very dangerous as far as uh, genesis of obesity is concerned. Right. And certain eating disorders, certain psychological disorders uh, have faulty eating patterns. Like binge eating disorder is there in during times of distress, during times of anxiety, or if a person is feeling too depressed, they resort to binge eating to relieve their distress. So which leads to obesity. So in approximately 30% obese individual, the binge eating pattern has been found. So this is very common. And in short period of time, person consumes lot of calories. Uh, and this is also associated with depressed mood. Um and whenever there are interpersonal conflicts, such people resort to binge eating. Food is used to block out the world and escape from unpleasant life circumstances. So they use food as a coping mechanism. Similarly, as much as 9% of obese individuals present with night eating complaints. This is also very common among psychologically distressed individuals, and other individuals who are having some kind of psychological morbidity like depression or anxiety. Usually, what happens that uh, in all psychological disorders, sleep disturbances are very common, and people are waking up at late hours of the night, and during that period of time they consume lot of calories, they lot of carbohydrates, lot of sweets, uh, because like they are everyone else in the family is sleeping, they are alone and they are awake for the long through the long night, so they tend to eat lot of calories. So typically it is described as consuming more than 50% of daily calories after the evening meal, when they are awake during the night. The night eating pattern is very common. uh, Various psychological stressors also, um, uh, and mood disorders like depressive spectrum disorders, as I said, because of various things like they lead to binge eating, they lead to night eating. So in many studies, like as much as 50% of obese binge eaters present with clinically significant dysphoria, as compared to only 5% of obese non-bingers. So these are the important psychological factors associated with obesity. The other part of the coin, or the other part of the story, other side of the coin is the psychological consequences also. The obesity has very detrimental psychological consequences, which leads to the vicious cycle. Like the underlying psychological stress in enhancing obesity, and obesity in turn, because of psychological consequences, leading further to a worsening of psychological symptoms. So, because in our culture, beauty ideals are thin and highly unrealistic, overweight people are subject of teasing, bias, and discrimination. So, this leads to psychological stressors and various psychological issues. That too, more frequently among the children and adolescents. Uh, so low self-esteem is very, very common among obese individuals, and depression is very common in morbidly obese. As much as 90% of morbidly obese have clinically significant depressive disorders. Moderately obese have like more than 50% have clinically significant depressive disorder. Next slide, ma'am. So if we, as we have seen that obesity has so many comorbidities, if you see the the incidence of depression is so high among it is surpassing almost all other physical comorbidities. So psychological impact is this high. Yeah. So again, at workplaces and at different places in society, these people face harassment, prejudice, discrimination. They have limited number of friends. Dating and marriage is like problematic for such individuals, which further lead to this vicious cycle of stress, worsening of psychological comorbidity, and further they resort to resort back to eating as their friend in hours of distress. Economic consequences of obesity are very well known. Like these people are less hired. They in their organizations they face discrimination uh, uh, so that leads to further psychological stress. Now coming to the childhood obesity, ma'am. So nowadays this is all-time high because of late in last 1 decade or 2 decades, the lifestyle has drastically changed, and uh, children have stopped. Literally, so many children have stopped playing outdoors. So children are spending a lot of time on social media. They are playing video games. They are too busy with their strict study academic curriculum also, and स्कूल से आए ट्यूशन चले गए ट्यूशन से आए थोड़ा सा टाइम है उसमें भी सोशल मीडिया एंड वीडियो गेम्स खेलने सो their physical activity has reduced to a drastic level and ultimately leading to uh, all-time high obesity in children and adolescents, and which is further leading to so many physical comorbidities also. So, under 5 years age group of in last 2 decades, the obesity incidence has increased from 32 million to 41 million, like almost 11 million children have got obese in last 2 decades. And in India, it is more prevalent among high income urban areas, but it is now disproportionately increasing in rural population and low income populations also. So it is there in all economic uh, categories. We have discussed, it is the most important is factor associated with childhood and adolescent obesity, sedentary behaviors. uh, lifestyle is the key actually, and so children and adolescents are at all time are having all time low physical activity levels, and
Hello.
this sedentary lifestyle has led to all time high incidence of obesity, and along with that there is so much stressful lifestyle among children and adolescents, uh, and it has a on the further strengthening the bidirectional consequences, like it has further uh, has detrimental effect on their psychological well-being. Such children uh, have high incidence of depression, sadness, anger, and further overeating. Depression is very typical sign, and usually the first manifestation during in obese adolescents. Now coming to the treatment strategies, right? So the most important uh, thing um, is number one, lifestyle changes, the most important key to the treatment. And as far as psychological aspect is concerned, so most important thing is the uh, cognitive techniques which we resort to treat obese individuals. There are cognitive techniques, and there are uh, uh, motivational enhancing techniques, which are very effective therapies as far as treatment is concerned. Providing a stigma free, family centered approach, especially in case of children, is very important. Role modeling by the parents is the key. So, because parents' lifestyle is equally worse these days, and the children uh, follow their parents, and the parents are role model for the children. So, if the parents are busy on their social media and with their mobile phones and in front of television, not doing exercise, this is a big role modeling for the children, and they follow suit, and then they become victim of sedentary lifestyle and obesity. Next slide, ma'am. So behavioral interventions are very important, and the aim is to have realistic goals. Realistic goals in weight loss management and weight management are very important. So weight management should be slow and steady weight loss by making gradual changes in eating and exercise habits, and uh, we need to be like consistent over long period of time to prevent relapses. Next slide, ma'am. So setting weight loss goals is very important. Traditional goal of attaining ideal body won't work actually. It doesn't work in so many cases. People start very enthusiastically, they have unrealistic goals, and for few weeks they have exhaustive they do exhaustive efforts, but ultimately because the weight loss cannot be achieved that fast, and after exhaustive effort, when they see that there is not much of the result, then they suddenly give up also. So the target should be slow and steady weight loss, and with realistic targets, and we one should make a proper roadmap of diet and exercise and over a period of time, so that the goals, short small goals, can be achieved in a realistic manner, and they should not be like faltering in between. We should also understand that there is a deep dream weight and there is a happy weight. So again, realistic targets should be set. Like, and no one, not everyone can become a model or like a film star, having ideal body and ideal weight. So one should make targets and realistic targets in proportion to their uh, time constraints, and in proportion to their lifestyle and their profession, so that those realistic weight weight targets can be met. Like it is explained that a person said, I want to lose 30%, and after a lot of effort they lose 10%, so they consider that they have failed, and as a consequence they again become depressed, then start binging, and they again regain. तो जो 10% लूज किया था वो भी रिगेन हो गया अनरियलिस्टिक टारगेट की वजह से. Psychosocial support is very important. Positive emotional support by the peers, by the family members, especially by the parents and by the spouse is very very important. Obese individuals should get all the possible emotional support, and at social and occupational level also they should be rehabilitated so that they can continue their effort in this management of obesity. Then relapse prevention is again very important. Uh, uh, for relapse prevention, one has to identify the risks, high risk situations. Like if a person is psychologically distressed, so he has to find out healthy coping mechanisms. Beforehand, he has to make a list of the coping mechanisms. He should the social support and the family support can be a good uh, help in this area. Uh, they should identify their mistakes and lapses and should not repeat them. And then there are several behavioral methods. If there is an underlying uh, psychopathology, then we can address it also. And the behavioral methods aims at improving the cognitions. There are certain faulty cognitions associated uh, with food and with the lifestyle. So these cognitions, if get rectified, then it is a big help in preventing the relapses. So psychiatrists and psychologists can act as planner and facilitators of the behavioral treatment. If there are psychiatric comorbidities, which are a very common cause of weight gain, they should be addressed properly. And for screening and long-term management of the patient, especially if the patient is going for obesity surgery, like bariatric surgery, the psychological well-being and psychological fitness before the surgery is very important. And post-surgery also, there are so many lifestyle changes required. So psychiatry is an important role to play in this team. Thank you.
Yeah. Thank you very much, Dr. Samyak. It was really a very comprehensive talk. And without wasting much time, अभी जो हमारे लिए सबसे important topic है, जो हमने रखा सबसे बाद में है, लेकिन सबसे ज़्यादा important topic है, that is diet. तो डाइट में सारी कहानी घूम फिर कर आती है डाइट और एक्सरसाइज पे. लाइफस्टाइल मैनेजमेंट विच इंक्लूड्स डाइट. डाइट का बहुत इंपॉर्टेंट रोल है. अब हमारे साथ प्रॉब्लम आती है कि हम कहते हैं कैलोरी काउंटिंग करनी चाहिए, इतनी कैलोरी से ज़्यादा नहीं लेना चाहिए, लेकिन हम ये कैलोरीज कैसे, हमारे जो आसपास हमारे पास अवेलेबल फूड है उसमें से हम कैसे एक्सट्रैक्ट करें कि हमें क्या खाना है क्या नहीं खाना है. इनफैक्ट फ्रूट्स में भी कुछ ऐसे फ्रूट्स होते हैं जो कि कहते हैं कि उससे कि ओबेसिटी बढ़ती है. तो ये सारी जो भी बेसिक इंफॉर्मेशन है, टिप्स एंड ट्रिक्स है, सजेस्ट अभी कोई भी हमारे साथ हमारे पार्टिसिपेंट्स है, बिल्कुल हमें छोड़ के ना जाए, क्योंकि एक बहुत ही इंपॉर्टेंट टॉक हमारी होने वाली है, जिसके लिए मैं इनवाइट करूंगी डॉक्टर निरुपमा को. शी इज अ डाइटिशियन at SGPGIMS Lucknow, and I request to please start. And I just request कि डॉक्टर निरुपमा, इफ हम थोड़ा सा ब्रीफ और अगर हम एक्सपेडिट करें तो हमारे पास एक अच्छा टाइम मिल सकता है जिसमें कि हम सभी की क्वेरीज ले सकते हैं, क्वेश्चन आंसर ले सकते हैं. तो आई रिक्वेस्ट ऑल ओवर टू यू डॉक्टर निरुपमा.
Sure. Thank you, Dr. Sudhi. Thanks for giving me opportunity to speak on obesity management and bariatric surgery. So I will not talk about the BMI and waist hip ratio because previous speakers has already talked about it. But next slide, please. How to calculate, that is weight upon height square in meter, and waist circumferences and hip circumferences just divided in both, and then the WHR will come, and that is that also will help to manage the obesity as well as to detect the obesity type of obesity also. Next slide, please. So we are talking about the BMI. So now for Asia Pacific, the BMI ranges has been changed. For underweight, it is 18.5, and for normal, it is 18.5 to 22.9. And along with that, overweight and obesity grade 1, grade 2. So we have to think about that. What are the major, what BMI we can suggest we can take for the surgery. Next slide, please. So Dr. Sudhi has told me to talk about the practical aspects. So dietary principle of obesity, it is very important. How much calorie has to be given to the patient? So for my practice, I always, for obesity, if it is 20 kgs of more than the ideal body weight, then I always say 1,000 calories दे देते हैं, 1,200 calorie दे देते हैं, and it is actually, it works. If we are calculating the 1,200 calories, it will give me more food that we doctors or we the medical professionalists are not able to eat even. But when we are counseling to the patient, when we are talking to the patient, the problems are coming. Roti is the same too, but the size of the chapati is very important. That is more or less. I am audible or not?
Yeah, you're absolutely audible.
So for sedentary, if a person is sedentary worker, 20 kilocalorie per kg of body weight, protein should not be less than, for all category, 1 to 1.2, and we can go for the 1.5 gram per kg of body weight, means at least 0.8 to 1 gram of per kg body weight. It is very important to give all the patient the protein and the carbohydrate. We talk about the, for bariatric surgery, if we talk about the 40% of total calorie, and that is not possible in Indian population, specifically in North India, because North or South India, because our major meal is the carbohydrate. So we used to stick on, we try to calculate, we try to give 55 to 60% of total calorie, and fat for the, even for the obese patient and for the diabetic with comorbidity, it is better to give for the step 2 diet, that is 20% of total calorie, including saturated and unsaturated fats. For moderate, 25 kilocalorie per kg of ideal body weight, and for heavy worker, should not go more than 30 kilocalories. And I think if we calculate 30 kilocalories, also very high. But if the person is very heavy worker and still obese, so we cannot make very less calories. And how to calculate the ideal body weight, in brief, I would like to tell. That is, whatever is your height, like my height is 164 centimeter. So make it 164 in a meter, and meter square, like it is coming 2.56. So just, and it multiply with 22, the ideal body weight will come approximately 59 kg. So this is the simplest way, and the 22 is a BMI. So it is better to calculate with the 22 and the height square in meter into 22. The whatever weight is coming will be the ideal body weight. We should not calculate the calorie with the present weight. Like if a person is 70 kilocalorie and if we are calculating is 25 or 20 kilocalorie, 1400 kilocalories is coming, so it is not going to lose the weight. It can maintain the weight. So for weight loss, it is necessary to come to the ideal body weight and calculate the calories with ideal body weight. Sorry. Next slide. Yes. Please take the photo of this. This is a nutritive value of per 100 gram. This is the commonly used food items like milk, skimmed milk, toned milk, buffalo's milk. Buffalo's milk or full cream milk is the same, approximate same calories. Paneer, dal, all type of pulses. This is the 100 gram values. So this is just a brief. Next slide. Component of balance and healthy thali should be carbohydrate, protein, fat, vitamins, minerals, fibers, and fluids. So previous speakers has talked about the vitamins, multivitamins, protein, and everything. So it is very important to get all the food from the natural food products as well as supplements whenever and wherever it is required. As for the bariatric surgery, I have seen means many of the times it is bypass or ballooning, many things are there. I'm not expert of that, but sometimes it requires supplementation also. But along with that, from the natural food products, it is very important to satisfy ourselves, because we the Indians, if we'll not chew na, we will not feel like we are full. So it is very important to get the food from the natural sources, that is whole grains and cereals, whole pulses and legumes, all types of vegetables. Even potato and shakarkand is also very important because it contains very good amount of minerals that is requires. Like I would like to give an example. Suran, everybody knows suran. We used to make surans vegetable in Deepavali. Why? Because the one serving of suran will fulfill the requirement of the whole of the year. This is just an example. So all type all type of vegetables should be included in our diet, all type of fruits, not only the kiwi and the apple. Nowadays it has started, like every patient who is coming from the, even for the very back rural areas, they are taking kiwi, 25 rupees kiwi, but they are not eating the amla, which is easily available in their areas. This is also, Dr. Sudhi has told me, like, just give a brief of the diet. So 1200 to 1300 kilocalorie and 45 gram of protein. I have not included the non-veg products. If anybody anyone is non-vegetarian, can add egg white. So cereals, please backslide. Cereals 150 to 200 gram, means if we'll take approximately 20 gram of one serving of a chapati, very small नींबू के साइज का जो लोई होगा, नींबू से थोड़ा सा बड़ा जो साइज होगा, वो अप्रोक्सीमेटली 20 टू 25 ग्राम का होगा. तो अगर हम देखें 200 ग्राम में कितना, 20 ग्राम के हिसाब से जो रोटी का मात्रा आएगी, उसको हम पूरे दिन में डिवाइड कर सकते हैं, ब्रेकफास्ट, लंच और डिनर में. along with that 30 gram of dal. I have done the survey, and in my 20 years of experience, I have seen the commonly what we are making the the dal we are making, it is not less than 25 to 30 gram. So 30 gram of pulses, any type of pulses you can add, like rajma, chole, chana, udad, moong, masoor, whatever pulses we can use, we can use in our daily routine. 300 ml of milk. If someone has milk intolerance, can add dahi, can add 25 gram of paneer in place of milk. Fruits and vegetables 500 to 600 gram. In my next slides, I will show what is 100 gram of pyaj, what is 100 gram of tomato, so that everyone can understand what to prescribe to the patient. If you are not having the dietitian, if you are having the dietitian, then definitely they will tell. Salads, approximately 300 gram of salads is necessary. So the vegetable and fruit part should be at least 1000 gram. It looks very high. 1000 ग्राम सब्जी कैसे खाएंगे, but if we eat like 1 कटोरी of vegetable, 3 katoris of vegetable, breakfast, lunch and dinner, it contains approximately 150 and 150, and one fruit, approximately one fruit if you are taking, it means 100 to 150 gram. Salads, if we'll take one pyaj and one tomato and one kheera, this will come 300 gram of salad. So it is very easy to calculate and to prescribe to the patient, and to convince the patient to take this much amount of food in whole day, distribute in whole day. Like my previous speaker Dr. Samyak was talking about how to patients are doing binge eating. For that binge eating, it is very important to prescribe, to make them to meet dietitian, and to take all these free foods, it's just containing very less calories. And there is nothing like nothing diet like free of fat. Fat should not be, the visible fat or oil should not be less than 15 ml. Sources of complex carbohydrate included in our diet, it is shown in the vegetables, pulses, legumes, millets can be taken. Next slide please. Simple carbohydrate should be avoided. If we are going for the bariatric surgery, means we are going a next step, a very next step. So it is very important to avoid these carbohydrate rich food, simple carbohydrate rich food, but it is not possible. Again, we have Diwali, Dashera, Eid, many festivals are there, so that it is necessary, or it has become our part of our life. So very small amount and very precise amount should be taken with the advice of the doctor or the dietitian. Next slide, please. Fiber-rich foods are very important. After this, I would like to talk about the protein, which is not included in this slide. So animal protein or vegetable protein, both of the proteins now are the same. A person who is having not taking the non-veg products can combine the pulses, combine the cereal pulse combination, will get good amino acid and good type of protein. So a person can take the all type of pulses, soya bean, paneer can be taken, milk and milk products can be taken. Along with that, if a person is non-vegetarian, egg white is very important. It contains a very protein, and it is better to avoid that yolk part. If sometimes if it is required, or if you want to have, of course, yes, you can take, but not on regular basis, not on daily basis. But egg white can be taken daily basis. Fish can be taken not fried, but roasted at home, not from the outside it, because outside whatever they are telling, it's not truth. It's not truth. So if a person want to take fish or chicken, can be taken, but with less fat, or barbecue, or roasted, or boiled form. Fiber rich food is very important. Previous slide please. For the satiety, person is for going for the bariatric surgery, and peri-operatively we are preparing the patient on 800 calories. So these fibers will work, because it is very important. If you are giving 500 to 6 gram of salad in whole day, distributing in whole day, this will give satiety. Whenever you are eating, if you are taking for example, we are talking about the detox water. We are chopping kheera, cucumber, and chia seeds, and many things. This will give satiety. Calorie is 20, but giving satiety for 3 hours. So these fiber rich foods are very important. Whenever you are eating fruits, try to take it with husk, with chilka, wherever it is, with wherever it can be taken. Try to use all the pulses with chilka, which is important. Arhar ke dal ke alawa, all the pulses can be taken with the chilka. So, and I would like to add one more thing, that's millets. We all are talking about the millets. Millets are good, but it contains the same calorie and same carbohydrate as the wheat. So while preparing a millet roti, it is very important, see the portion size. The millet chapati is just double of the gehu chapati. So if you are taking 2 chapati of gehu, so you have to take only 1 chapati of millets. Next slide please. This is the free food slide, because slides are quite jumbled. Free foods I was talking about, which contains very less calorie, 20 calorie. It's nibu pani, clear soups, or detox waters, बिना चीनी, बिना दूध वाली चाय, coffee, patli lassi, patla mattha can be taken as a free food, and this will not give you calorie, but the satiety, again I am saying, this is very much required for the preparing patients for the bariatric surgery, because it will work after the surgery also. Next slide please. I will not talk much about the glycemic index. Glycemic index is very important, because when you are taking food high glycemic index, this will again insulin requirement will increase, and then you will feel hungry, then again it will come down. So it is very important to take select the low glycemic index, which I have already discussed. Next slide please. Next slide please. This can be seen like low in low GI. All pulses can be taken, fruits can be taken. Some fruits are there which can be the wheat rotis in the medium GI. So if you are adding more of husk, it will come to the low GI. Next slide, please. Dr. Sudhi was talking about the fruits can be taken or cannot be taken. So not daily, but aam or kela, aam ka season or aam nahi khaye, it is not possible. So 1 or 2 pieces of mango can be taken even for the diabetic patient and for the obese patient. But we have to be psychologically or mentally prepared for it. Dietary management or weight loss is a very sensitive matter, because persons should be mentally strong for this. It is very important. Yes, aapko milega, but how much, this has to be tell every time, like you can take but very less amount, you can take but very less amount. Next slide please. Next slide please. Next slide, because I have already talked about it. Fat, backside fat set, yes, pufa, and so all the refined oils, sarso ka tel, dry fruits can be taken. But for the dry fruits, I will show the slides next please. We should cook smart. Yes, next. So frying is not advisable, like not for at all, but not on daily basis. Rest of the methods, boiling, grilling, barbecue, steam, or roasting is better. Next slide, please. sugar is not coming only from the table sugars, but these sugar-free biscuits, oats biscuit, sugar-free juices, sugar-free sweets, sugar-free things. So stop all these sugar-free products. They take the natural products. Next, please. Next, please. This is yes. Previous slide. Measurement: 1 cup is equal to 150 ml. 1 bowl approximately 150 ml. 1 feast मुट्ठी बंधी हुई 25 ग्राम. 25 ग्राम दाल, 25 ग्राम चना, 25 ग्राम मूंगफली विल कम. हैंडफुल अगर आप हाथ खोल के लेते हैं तो वो लगभग 100 ग्राम लैया चना या 100 ग्राम दाल, 100 ग्राम मतलब एक जस्ट आपको बताना है अगर किसी को, तो यू कैन टेल लाइक कि एक मुट्ठी बंद मुट्ठी लेंगे तो 25 ग्राम आएगा और खुली मुट्ठी लेंगे तो इसमें अप्रोक्सीमेटली 100 ग्राम तक अनाज या 100 ग्राम तक कोई भी सीरियल्स आ सकता है. ग्लास का साइज अप्रोक्सीमेटली जो यूज होता है वो 250 ml. 1 teaspoon, everybody knows 5 ml. Table spoon is 15 ml. So always ask, because nobody is using teaspoon, everybody is using tablespoon even for eating. So whenever you are asking to the patient how much oil you are using, so it is the best idea to ask how many members in the family and how much oil in any type of oil or ghee you are using in a month, and divide in that, so that you will able to calculate. This is the slide I was talking about ki you will get an idea. So 1 pyaj is approximately it's a medium size of pyaj, approximately 80 to 90 gram. 1 orange is approximately 80 to 90 gram. One banana is it's a 99 gram. It is showing without chilka. It will come approximately, I think it is without chilka. No, it's with chilka. 99 gram. If we'll remove the chilka, approximately 70 gram it will. Next slide, please. Yes. काजू खाना है, बादाम खाना है तो मुट्ठी भर के खाते हैं. सो एक काजू 2 ग्राम का है, 10 काजू खाया तो अप्रोक्सीमेटली 10 दूनी 20 ग्राम हो गया. 20 ग्राम अप्रोक्सीमेटली 120 कैलोरीज हो जाता है. सो वाइल ईटिंग दीज ड्राई फ्रूट्स, ऑलवेज रिमेंबर हाउ मच. सो वी द डाइटिशियन से 4 बादाम खाना है. सामने वाला मरीज कहता है कि 4 बादाम में क्या होता है मैडम, काजू कोई 4 खाता है क्या? सो इट इज वेरी इंपॉर्टेंट टू know to the medical professionalist ki it should not be taken more than that because of the calorie content. It's good, it is containing good omega 3 fatty acid. What to do if we are if we already we are already if the person is already obese, we are contributing it. So this is the chukandar, tomato, shimla mirch and potato. 1 potato, 1 chapati is equal in carbohydrate as well as in the calorie. How to satisfy the satiety? Plain soup, whatever soup you are making, don't waste, don't throw out the vegetable which are used in churning and all. Use it as it is. You can eat that also. That will give the satiety. If we are even I have tried, if you are taking one full plate of salad and you want to eat 2 chapatis, you won't be able to eat. Same thing is with dal. Don't take the plain dal. Add some vegetables like lauki, palak, many things. You can use atta can be dough can be made with the like palak or dal or many things. Many vegetables are available. Stuffing can be done because these vegetables are very less in calories, not more than 60 to 70 calorie. If we talk about the gobi and all, sometimes it is higher side. Even if we are making the omelette, we can make palak omelette, we can make tomato omelette. Many options are available, but we have to be very clear like how much and how to cook the food. Next, please. Same thing is with when we are taking the salad, we can use if you are taking the non-veg, it doesn't contain any calories. So if you are adding plenty of salads or green vegetables or any vegetable which is available, you are adding more less calories and more fiber, so that it is not going to contribute to deposit as a fat. This will bind with the carbohydrate and not raise the blood sugars, as well as not contributing. It will excrete out if you'll do exercise and more. 5 gram carb snack is the very one more click please. No, one more click. Yes. So this is a 5 gram snacks. That's vegetable salads, mattha, matha, milk, coconut water, homemade vegetable, ampana, bel sharbat can be taken, and it is giving 5 gram carbohydrate and not more than 25 to 30 calories. So whenever we are feeling hungry, when we are advising to the patient to have small frequent meals, of course can be taken, but small frequent meals every time cooking is not possible, so these things can be taken. So it is not required cooking, but can be taken as it is. Next slide please. This is a 10 gram snacks. I am talking about the carbohydrate because carbohydrate is very much important for the weight management as well as for the weight reduction, for the bariatric surgery also. Laya chana 1 cup. If you are taking laya chana, don't take only laya chana, add plenty of salads in that, so that it will increase the amount, and it will work as a dinner or as a lunch also. You need not to take extra. When you are taking dahi, you can add kheera, you can add tomato. Many things are there that can be added, and not increasing the calories as well as maintaining the protein. Next slide please. This is a 15 gram snacks which can be given as a breakfast or lunch snack or lunch options. That is chila, sprouted chana. We are eating idli, only plain idli. Why not to add plenty of vegetables, chopped vegetables in the batter as well as in the saute in the pan, and then can be taken. It is tasty also. Next slide please. Next. Thank you. Oh, rest of the slides in my.
Yeah.
But I think this is not sufficient. I need 2-3 more lectures for this bariatric surgery and for the obesity management. This is just a brief things.
Yeah, thank you very much, Dr. Nirupma. It was really a very insightful, क्योंकि इसमें बहुत सारे टिप्स एंड ट्रिक्स थे, बहुत सारे फूड आइटम्स एक्चुअली हमें पता चले कि ये भी किए जा सकते हैं। और जो सबसे बड़ी प्रॉब्लम आती है किसी भी ओबीस पेशेंट को वाइल ड्यूरिंग देयर वेट लॉस जर्नी इज हंगर, कि उनको बीच बीच में बहुत क्रेविंग होती है और उस वक्त उन्हें समझ नहीं आता क्या। सो देयर आर वेरियस फूड ऑप्शंस दैट यू हैव सजेस्टेड
And choices also, it's very important.
this choice, and some of them can be used as a major meal also, like they can
Yes.
replace the major meal. Thank you very much. So I'm now quickly we have good amount of questions that we have, so important. So sir, sabse pehle the question is for you, for Sondhi sir. So we have because people have shown their interest for GLP-1. One question we received from Dr. Ruchita Chaudhary: is it recommended to use semi-glutide in non-diabetic obese? Like patient is non-diabetic but still obese है, तो क्या आप देना चाहेंगे उसे?
And the answer is dogmatic yes, because they are the treatment, one of the best pharmacological treatment for non-diabetic obesity, right? So there are a lot of studies available. So yes, dogmatic yes.
Great, sir. Sir, GLP-1 pe hi, there is another question. What are the age? Dr. Rohit has asked this question. What are the age consideration for starting pharmacological treatment, and what routine investigations are mandatory once you start pharmacological treatment? Sir, I would like to add one more point into this question. Is it the first line of treatment that you would like to start in any obese patient, or you would like to start with maybe orlistat and lifestyle management? तो of course होता ही होगा, but is it the first line any patient when come कि अच्छा हमने सब लाइफस्टाइल कर लिया, नहीं हो रहा है, तो आप हमें कुछ दवाई दे दीजिए and we straight forward start GLP-1?
सबसे पहले तो लाइफस्टाइल मैनेजमेंट करते ही करते हैं सभी मरीजों में, और अनफॉर्चुनेटली जो GLP-1 की जो एंटी ओबेसिटी डोजेज जो इंजेक्शन हैं वो हिंदुस्तान में अवेलेबल हैं ही नहीं अभी. So we just have a tablet of semaglutide with the name of Rybelsus, and that doesn't cause weight loss to that extent, and that is not, recommended for non-diabetic obese individual. तो unfortunately हम लोगों के पास जो non-diabetic obese individual के लिए GLP-1 के options हैं वो ग्रे मार्केट में है, काफी कॉस्टली है, लेकिन अभी है अवेलेबल नहीं. तो अगर आप मुझसे पूछें so you'll be surprised that I use very strange. I sometimes use topiramate as a weight loss drug, and patient अगर इतना सा भी कह देता मुझे सिर में दर्द है, तो I said okay, take topiramate because I want him or her to reduce weight. Orlistat is very costly as well as it is not very effective on a long term basis. So not that good. So right now we don't have many options in India. I'm sorry to say that. I mean, हम लोगों के पास ज्यादा ऑप्शन नहीं है. एक जरूरी है कि अगर डायबिटिक पेशेंट है तो उसमें हम लोग डेफिनेटली GLP-1 दे देते हैं जिससे वेट लॉस होता है. हम SGLT2 इनहिबिटर दे देते हैं जिनसे वेट लॉस होता है, और ग्लिप्टिन्स जो वेट न्यूट्रल है. So we should remember which are the weight neutral and which are the weight gainers. हम लोगों ने डॉक्टर्स ने बहुत सारे मरीजों को मोटापा दिया है बिकॉज हम लोग देख नहीं रहे हैं.
Yes, sir. Sir, Magan sir, want to add on some point?
So just to add to sir's this thing that Rybelsus can be used for weight loss in non-diabetics, but it is an off-label use. Off-label means the company, yeah. Right. So that is the term off-label. You can tell the patient that it is not for you as such. If there are any unwanted side effects, that is your responsibility. Then the patient is interested, then he or she can go ahead.
Sure.
So there are many physicians that are with us right now, and they may would like to understand कि जो medicine जैसे कि या हम as a non physicians would like to understand कि सर ये जो medications हैं उनको लेने से क्या problem आती है patient को, what are the potential side effects that we must be, otherwise तो ये बिल्कुल over the counter भी हो सकते हैं, लोग बिल्कुल जाके ऑर्लिस्टेट के नाम से रीशेप के नाम से ले. तो व्हाट आर द पोटेंशियल साइड हजार्ड्स और साइड इफेक्ट्स ऑफ टेकिंग दोज ड्रग्स विदाउट मेडिकल सुपरविजन?
देखिए, ऑर्लिस्टेट काइंड की ड्रग जो है उसके साइड इफेक्ट्स मेनली डायरिया और ऐसे हैं, लेकिन ओवरऑल बहुत ज्यादा साइड इफेक्ट नहीं है और ओवरऑल इफेक्टिवनेस भी बहुत ज्यादा नहीं है. हमें 2-3 किलो वजन कम हो गया आपका तो उससे ज्यादा फर्क भी नहीं पड़ता. GLP-1 आर वेरी इफेक्टिव, और जिन डायबिटिक्स में हम GLP-1 और SGLT2 दोनों दे रहे हैं उनको काफी किसी को बड़ा ड्रामेटिक वेट लॉस हो रहा है. और किसी भी वेट लॉस ड्रग का अगर हम सारी स्टडीज देखें तो ऐसा होता है कि 50% पेशेंट में मॉडरेट वेट लॉस हुआ, 25% में बहुत खूब हुआ और 25% में बिल्कुल नहीं हुआ. आई मीन GLP-1 जब हम देते हैं तो सबसे बड़ा साइड इफेक्ट लॉस ऑफ एपेटाइट, नोजिया, वोमिटिंग, डायरिया, ये है मेन. और जब हम रिबेल्सिस की बात करें तो जब हम 3 से 7 मिलीग्राम, 7 से 14 मिलीग्राम पे लाते हैं तो कई सारे मेरे पेशेंट ने 14 मिलीग्राम की टैबलेट लेने से मना कर दिया. बोले साहब ऐसा हो गया कि मुझे पानी की भी प्यास नहीं लगती, मुझे भूख ही नहीं लगती, मुझे लग रहा है मैं मर जाऊं. हमें दैट काइंड ऑफ टेंडेंसी की जी, भूख बिल्कुल गायब हो गई है, बिल्कुल गायब हो गई है, कुछ खाने को मन नहीं करता, मन ही नहीं करता. सो बट दीज आर ओनली स्मॉल परसेंटेज. So these are the main side effects. I think GI side effects are the main. हमको GLP-1 जब हम डायबिटिक में यूज करते हैं तब हम केयरफुल होते हैं कि रेटिनोपैथी को पहले चेक करा लें, क्योंकि अभी भी ये क्लियर नहीं है. कुछ स्टडीज ये कहती हैं कि GLP-1 रेटिनोपैथी को बढ़ाती हैं, and there is still a study going on, and so we got to be very careful. If the patient has proliferative retinopathy, I think we should ideally avoid these even in a diabetic.
Fine, sir. Thank you. So, what about, because what we hear about these medications, they have a rebound effect. Whenever these medicines are stopped, the patient again tend to gain weight. So, what is your experience on this?
Absolutely. So, जैसे ही आप मेडिसिन बंद कर देंगे धीरे धीरे वो वेट सारा वापस आ जाएगा. So they have to be continued for indefinitely, for as long as possible, and it's not bad. I mean, like they are turning out to be, हमें अभी जो पाइपलाइन में है ये रिसर्चेस की, वो एंटी एजिंग है कि नहीं है, कि ये एंटी इन्फ्लेमेटरी है कि नहीं है, कि ये एंटी अल्जाइमर्स है कि नहीं है. सो बट देयर आर सम इंडिकेशंस दैट दे मे बी वेरी गुड. So I think in the next 10 years we'll come to know of their potential.
So there's a very nice special issue of Time which has come recently, and I recommend all of us who are treating obesity to read it. And they talk about willingness to pay index. So because of the cost of these drugs as of now, so they are talking about willingness to, because they are not covered by insurance in most cases in the US. So when they compared willingness to pay for bariatric surgery to as compared to the drugs, then there was less willingness to pay for these drugs because bariatric surgery was actually covered by their insurance. So,
I
but
know.
I think it is a matter of time only. Once these drugs become mainstream, we will have a good algorithm to follow when to recommend surgery, when to give medicine, when to combine both of these for best economic as well as health impacts.
And
Thank
Dr. Sudhi, you can actually look at the who's who of filmdom to diagnose which one are taking Ozempic and Wegovy. You can look
you.
at their face and you will be able to tell he is the patient, he's the person who's taking Wegovy.
Yes.
Karan Johar.
Karanjo, classical face.
Yeah. So this one last question to you, sir, and after that there is another question for Dr. Nirupma and Dr. Samyak. Sir, what is the safety profile in children? Like Sir
Uh,
Magan sir has told ki bariatric surgery is recommended after 18 years. So what about the obese children and
Right. So GLP-1
adolescents?
are now indicated over the age of 12. There have been many studies, many published in NEJM in 2022 also, and they are recommended after the age of 12, provided these children undergo lifestyle intervention and they don't lose weight. So anyone about 12 can be given GLP-1 analogs for reducing weight. And Sudhi, if you excuse me now, I can leave because I have some people waiting for dinner at home.
Yes, yes. So thank you very much for your inputs. So there are a couple. In fact, any questions if like people want to ask, they can message us in our group later on. From sir, we can get all these answered. So I thank you very much, sir, for your
Thank you.
valuable time and the insightful presentation. We learned a lot from you today.
Thank you.
Thank you.
Thank you, sir. It was great listening to you. Thank you, sir.
It
Thank you,
was
sir.
my pleasure.
Yes, sir. Thank you, sir. So there is one another question from Dr. Satish Kumar Arora. So who said he is not depression, he is not into depression, but he has a craving for sweets, always craving. How to take care? So first I'll ask Dr. Nirupma about this, and then Dr. Samay, because there is some sort of psychological involvement definitely. Because these sweets, what my information is, they secrete a lot of dopamine. I think that happy hormone in the brain, and the brain is then gradually addicted to that amount of sweetness. So mild sweetness will not give them that happiness. So first of all, Dr. Nirupma, are there any dietary supplements through which, and then Dr. Samyaki, how to handle this addiction?
For my patient, I used to tell that you can have the khajur dates can be taken, and khajur and with dry fruit laddu sort of thing, that not added any fat, not added any ghee or oil, just bind it, churn the khajur in the grinder, dry roast the dry fruits and make the grind the powder, and then that sweet can be taken. And if everyone is agree, I used to tell from last 20 years to my patients, one to two sugar free tablets. If this can give satisfaction to the person, a cup of milk and adding one sugar free tablet and khajur paste, and that can be taken as a sweet supplement. That will not increase much of the calories, because if a person is taking one or two pieces of khajur, this is going to be give only 40 to 50 calories and 10 gram of carbohydrate. So can be taken to at least not to take 200 to 250 calories at once.
And what
Dr.
about
Sam.
jaggery? And what about jaggery good?
If we
Can
talk
this
about
also
the
be used?
jaggery can also can be used, but to 5 gram of jaggery will give you approximately 25 to 30 calories, and that is not going to satisfy. So very small amount jaggery can be taken, of course can be taken, if the person, but if the person is diabetic, I won't prescribe that.
Yeah. And Dr. Samyak, how to handle this addiction?
Ma'am, see again, this is that dopamine circuit of reward. Like people can crave for carbo. Certain people have this craving for carbohydrate. It can give them some kind of psychological satisfaction or well-being, or maybe a feeling of upliftment after taking sugar. Again, but it has to be dealt at the cognitive level, ma'am. So they have to understand uh, that that this high they are getting through the sugar or through the carbohydrate, they have to replace it with something healthier. It could be anything else. It could be some exercise, could be some family time. We have to replace uh, that urge during the time of the urge, when they are having an urge for carbohydrates or sugar or sweets, with something healthy. And cognitive work has to be done. There are techniques like cognitive behavioral therapy and behavioral therapies are there, which teaches us to replace the faulty cognitions from the healthier cognitions.
So
So
basically, you
they are
mean to
very
say
effective.
कि basically you mean to say divert the mind through some means.
Yes, some
Yes.
healthier options other than consuming the sugar.
Yes, sir. So, Magan sir, would you like to add, like Dr. Nirupma said, ki, to the sugar-free, how much are you in favor of using sugar-free?
Uh,
Personally, I don't like using that.
see,
I'm not sure about you. Yeah.
yeah, so I think Dr. Nirupama is talking about people who can't take away, who can't do without the taste of sugar. So normally, what we advise to our patients is to completely avoid the taste, to avoid sugars completely, so that they start taking natural sugars like in fruits, and as she said, kajur is better. But if somebody cannot do without sugar, he wants the taste, then sugar free is an option. But then there are negative effects of sugar free, and they talk about renal failure and other things also. So I am personally not very comfortable telling them to take sugar free, but yes, once in a while, I don't think it will cause any.
Yeah. So
One or two tablets, like one tablet in a day is not harmful. It can be given, but if somebody is thinking like plenty of just to make sweet as a sharbat, so it can be
Yeah.
taken. This also I also don't prescribe it. That
So
can
there's
be.
one very important secret I would like to share here for Dr. Satish, if you are still with us. There is a plant called stevia. It is
Stevia, yes,
exactly like sugar free that you
yes.
can use during your sugar craving. So it will give some sort of satisfaction definitely there, and you have to keep yourself motivated not to take carbohydrate. Sir, then there are two questions, and sir, then I will come to Magan sir also. There is a question for Dr. Samyat. The question is, how do you handle major depression in obese patients since almost all antidepressants cause weight gain?
Yeah, ma'am. Of late, the psychopharmacology has evolved a lot, and we have better options. Like certain antidepressant can promote weight loss also. So we resort to molecules which, if pharmacologically we are treating them, so we resort to molecules which rather promote weight loss, like low dose fluoxetine, like 10 to 20 milligram in many individuals is found to promote weight loss. So we can use it for our advantage to treat depression as well as promote weight loss. Then certain non-SSRI, non-SNRI weight neutral antidepressants have evolved, vertioxetine and agomelatine. So newer antidepressants, bupropion, which have very less propensity to promote weight gain. So these agents can be used. But again, what we neglect usually in clinical practice is the role of behavioral therapy and cognitive behavioral therapy or psychotherapy. So in so many studies, the psychotherapy and cognitive behavioral therapy has validity as good as equal to medication. So if we resort to psychological treatment and less of the pharmacological treatment, if it is not very, if the depression is not very severe, then very low dose antidepressants, which don't have propensity to cause weight gain and certain have rather weight loss properties, clubbed with good psychotherapy, uh, is a good combination for promoting for treating depression and at the same time helping with the weight management.
Yeah, great. Thank you very much. And there is another question for Dr. Nirupma. इन्होंने पूछा है, does soybean as protein increases estrogen level? क्या ये बढ़ाता है? क्योंकि मेल्स में थोड़ा गायनिकोमेजिया का प्रॉब्लम होता है, फीमेल्स में menstrual irregularities की प्रॉब्लम होती है, ब्रेस्ट पेन की प्रॉब्लम बहुत होती है. And which vegetarian food is best for protein?
First as question's answer is no. We don't have evidence for like it is increasing the estrogen level. Second, second question, for vegetarian we can go for the milk and milk products and combination of pulses will be the good.
ओके, क्योंकि उसमें कहते हैं
And
सोया
soya bean can be
फ्लेवोनॉइड्स
used
होते हैं.
as a protein supplement. हाँ, isoflavones होते हैं, but we don't have evidence like it is increasing the
Estrogen
estrogen
बढ़ाते
level.
हैं.
Yes,
Yes, sir.
we can use dairy products and pulses as a protein supplements, as a protein product.
Yes, sir.
Ma'am, just
Okay, so
one question here. Is soya bean also known to cause thyroid abnormalities, ma'am?
No.
No. So
okay.
soya bean can be safely
Yes,
used.
can be taken. Soya bean, gobi, rajma can be taken for the thyroid patients also.
अब एक्चुअली द इम्पोर्टेंट पॉइंट इज कि हम कितना अमाउंट ले रहे हैं, तो एवरीथिंग इन मॉडरेशन इज ऑलवेज गुड.
Yes.
कई कई ऐसी जगह होती है जहाँ पे हम एक्सेस अमाउंट में लेते हैं, वहां पे इश्यूज आते हैं इस चीज को लेके. मगन सर के लिए एक इम्पोर्टेंट क्वेश्चन है वो, सर, हाउ डू यू डिसाइड,
Dr. Sudhi, can I take leave? My children are just running behind me.
just 2 minutes, sir, we are just about to conclude the session, if you could allow me.
If you allow.
Magan
If you have
sir,
questions,
हाँ, सो
yes, please.
मगन सर के लिए एक क्वेश्चन है, दैट विल बी आवर लास्ट क्वेश्चन एंड देन वी विल वाइंड ऑफ दिस. एंड एक आपको डिटॉक्स का भी और बताना है, कुछ ऐसे कहते हैं ना सुबह नींबू पानी पीना है, या फिर वो बहुत सारे डिफरेंट अलग तरीके के डिटॉक्स वाटर्स होते हैं. हाउ डू दे हेल्प, लाइक डू दे इंक्रीज द मेटाबॉलिज्म, हाउ डू दे हेल्प?
Yes, increases the metabolism, of course, yes. If you are adding lemon, as well as if you are adding dalchini, chia seeds, jeera, ajwain, many things are there. If you are taking, and one more thing, this is avoiding the food, taking food also. Morning, if you are taking 1 liter of this detox water, this is not, the person is not going to eat at least for 2 to 3 hours, because that 1 liter water or the 1 liter detox water should not be finished at once. So of course, and it also helps to reduce the weight. It is working. And after that, if you are doing, or before that, if you are before taking or after taking, after exercise, if you are taking, definitely it is helping. But
Fine.
I would like to, shahad can be taken, but if you are taking 1 to 2 teaspoon of shahad, just making it tasty, then it is increasing the calories because it contains calories.
Okay, so one last question from Dr. Magan, and then we will wind
Yes.
up this session. And before we wind off, I request all the speakers and all the participants to please switch on their camera, because as a protocol, we just take a selfie
Okay.
for our remembrance. And sir, how do you decide? Like earlier, there were gastric band ligation भी होता था and all. So अभी भी शायद उसका कुछ रोल है या वो खत्म हो गया? और डायरेक्टली व्हाट डू यू सजेस्ट, लाइक एनी पेशेंट जब जस्ट कम, तो शुड वी स्टार्ट विद स्लीव, अगर उसमें रीगेन होता है देन वी शुड गो फॉर द बाईपास, और कुछ पेशेंट्स में हम डायरेक्ट बाईपास करते हैं, तो इज देयर एनी स्ट्रैटेजी लाइक गैस्ट्रिक, पहले गैस्ट्रिक बैंड लाइगेशन का आप थोड़ा बताइए कि ये अभी भी है, बलूनिंग का अभी भी कंसेप्ट है या खत्म हो गया?
So gastric banding was the first bariatric surgery that was started. So gastric banding showed very good results in Australia, so it got popularized all over the world. But then when sleeve gastrectomy was started, it pushed gastric band out of this out of the view completely, because initially there were two options: gastric band and gastric bypass. Gastric bypass had malabsorption issues, so gastric band was preferred for those who just wanted weight loss and there were no metabolic factors. When there is diabetes, when there is dyslipidemia, there is obstructive sleep apnea, multiple factors of metabolic syndrome are there, then we prefer a bypass procedure, and we prefer pure restrictive sleeve gastrectomy sort of procedure when we want only weight loss. So this is most about it. About the gastric balloons, they were not very popular because half of the patients used to get them removed within a week of getting them inserted because of intractable nausea. So proper counseling was required, proper patient selection was required. Then now we have the swallowable balloon, but with the GLP-1 receptor agonists coming in, I think all these therapies will go, and endoscopic bariatric therapy along with GLP-1 receptor agonists and bariatric surgery for severe obesity, supplemented in post-op when there is weight regain with GLP-1 receptor agonists, will be the mainstay as of now, and let us see what research shows.
Thank you very much, sir. Okay, take one selfie. All the cameras are open. And now it was a really a wonderful, a fantastic evening full of academic feast. एंड आज हमने बहुत कुछ सीखा वो हमारे सारे स्पेशलिस्ट से. तो अगर मैं इन सारी चीज़ों को समराइज करूं तो फर्स्ट ऑफ ऑल वी नीड टू अंडरस्टैंड दैट जो ओबेसिटी है इट इज़ अ लाइफस्टाइल प्रॉब्लम. सो लाइफस्टाइल इज मस्ट, मतलब हमें चाहे जो भी मीन्स हो वी हैव टू करेक्ट आर लाइफस्टाइल टू अचीव द डिजायर्ड गोल्स. डाइट एंड एक्सरसाइज प्लेज अ वेरी वेरी इंपॉर्टेंट रोल. अगर आप सिर्फ डाइट करते हैं, एक्सरसाइज नहीं करते हैं, तो आपकी बॉडी का जो बेसल मेटाबॉलिक रेट है ऑटोमेटिकली कम हो जाएगा टू कंजर्व द एनर्जी एंड यू विल नॉट गेट द डिजायर्ड रिजल्ट. तो you have to spend the energy to get the desired result. जो मेडिसिन है और जो सर्जरी है दे हैव अ सप्लीमेंट्री रोल. इवन इफ you use either medicine or surgery, you have to resort to lifestyle. If you say you cannot maintain your lifestyle, both the surgery and medicines are prone to fail. So कुछ important quick टिप्स हैं जो कि मैंने इन लोगों से सीखे हैं, आज आप सभी से सीखे हैं. सबसे पहले कि एक बहुत ही इंपॉर्टेंट आर्टिकल मैं पढ़ रही थी कि ओबेसिटी का रेट इतना ज़्यादा सर्ज क्यों हो गया. तो हमें ये समझना होगा कि ओबेसिटी का रेट इतना सर्ज इसलिए हो गया क्योंकि आप होममेड फूड चाहे जितना भी खाएं, लेकिन जब अभी द सर्च इज इन द आउटसाइड फूड, जो हम ईटिंग आउटसाइड जो इतना फ्रीक्वेंटली हो गया है, पैकेज फूड्स इतने फ्रीक्वेंटली हो गए हैं, केक्स एंड अदर प्रोडक्ट्स, दीज आर मेड फॉर प्रॉफिट मेकिंग and not for the health. So these mayonnaise, cakes, these are the source of fat and the calories that we are consuming. And so also we understood that these sugary foods, they increases the dopamine level. फिर आपको जो less sugary food होता है, you don't enjoy those foods, and gradually you keep on adding on sugars and adding on calories. So simple important is don't use the simple sugars to for your hunger. First you eat everything and use those sweets during festivals for your taste only and not to fill your tummy. So these are some of the tips and tricks, and I wanted to share with you all. And a regular exercise for fitness, this is very very important. And आई होप हम मेरे साथ हमारे टीम के साथ आप लोगों ने भी आज बहुत कुछ सीखा होगा. सो दिस वाज द फर्स्ट सेशन ऑफ द न्यू ईयर जनवरी 2025 and it was really a big success because we learned a lot. As already told, these meetings are recorded and we upload them on YouTube for future references. So anyone who due to any chance has missed the meeting can revisit our meeting and can have a look on this and can learn again. हमारी जो अगली मीटिंग होगी फरवरी में होगी, that will be on breast. So those who practice breast, I request please keep connected with us. The details will be shared soon. And with this, I would like, if any one of you want to say something about this program or this forum, that would be a delight for me as well as my team.
Very well conceptualized program, ma'am. Very informative. And congratulations to you for planning such a useful and pertinent topic, which is
Thank you.
most required these days.
Thank you very much, Dr. Samek. And really, role of psychiatrist cannot be overemphasized. You really do a very good job while you counsel these patients. Yeah. So
सभी स्पीकर्स का बहुत अच्छा प्रेजेंटेशन था और बहुत अच्छा लगा, और डाइट्स के बारे में तो और मतलब काफी अच्छा रहा.
thank you
Thank
very
you
much,
all.
sir. Thank you.
Dr. Sudhi, thank you so much. This is a holistic approach, not only the pharmacological and surgery. It is very important to keep all together. Thank you so much.
Thank you very much. Thank you, Dr. Nirupma. Yeah.
Thank you, madam. Very informative. Thank you very much for including me. It was very informative for me also. Especially Dr. Nirupama has given a lot of very good information. I took a lot of screenshots from her presentation.
Thank you, sir.
Thank you.
Yeah, me too. And sir, all these things will be there on YouTube after a short while. And with this, I would like to thank you all for your patient hearing and being with us as always. And with this, now I conclude the meeting with a very, very good night to you all.
Good
So
night.
stay happy, stay healthy. और एक बहुत अच्छा डॉक्टर मोनिका ने लिखा था, अब कुछ हेल्दी हो जाए, कुछ मीठा हो जाए की जगह होगा कुछ हेल्दी हो जाए.
Yes.
एंड चीज और सबसे लास्ट में क्या होता है, जो खाना होता है ना, हम आधा खाना तो अपनी आंखों से खाते हैं. सो जो हमारा कन्वेंशनल फूड है, अगर हम अपनी जो आजकल हमारे पास बहुत सारे रिसोर्सेज हैं थ्रू यूट्यूब, अगर हम उसको बहुत अच्छे से प्रेजेंट करके
Exactly.
प्रेजेंट करें अपने बच्चों को भी, तो आधा खाना तो वो अपनी आंखों से खाते हैं और होपफुली दे विल एक्सेप्ट दैट होम कुक्ड फूड बेटर देन द आउटसाइड फूड. तो विद दिस आई नाउ
अगर कोई ऐसा लिरिक्स तैयार करे कि अब कुछ हेल्दी हो जाए और
Yeah.
डॉक्टर उसको सेलिब्रेट करे, प्रमोट करे, तो दैट विल बी नाइस.
That's a very good idea, and we'll certainly
Good
work
idea.
on in this regard. And thank you very much once again. And I request you all, you can now leave the meeting.
Thank you.
Thank you,
Thank
thank
you.
you. With a promise to meet again, maybe in some other meeting.
Sure,
Thank you.
sure, sure,
Bye.
sure.